Hi, good evening, everyone, and welcome to this evening's Mind the Bleak webinar. Today, Dr. Wendy Tan, who's an F2, is going to be covering verification and certification of death, which is something that as F1s and F2s we'll be doing a lot of. But before we hand over to Wendy, we're just going to have a quick word from Dan from the BMA, who's just going to run us through some of the things that they can do for us during our foundation years. So if we just hand over to Dan now.
So I'll just share my screen. Okay, doke. So yeah, there's a QR code on the screen. Yeah, and there'll be a couple of links shared in the chat as well. Sorry if you've heard me out of the chat before, but yeah. Anyway, it's all good stuff. It's just about the BMA, how we can sort of support you, and just sort of a refresher. Really, I'm sure a lot of you are members or you members before. So yeah, a couple of well, there's a couple of links on the screen. So one is about joining, the other one's about an employment guidance support pack. So basically, yeah, we've created an employment guide, and we've made sort of a bit of a support pack for students. It doesn't matter if you're a member or not. Everyone can have it, because it also means it's just a way of us sort of staying in touch with you. So yeah, including that, you get a junior doctor employment guide, so it sort of outlines sort of all the terms and conditions and stuff. We obviously negotiate the contracts, and we've negotiated the junior doctor contract, so it sort of talks about it inside out. Our ethics toolkit's in there as well as revision tips and tricks. There's a looking after yourself section, and there's a Q&A with Dr. Alex George. So some other bits on there, but yeah, scan that QR code, leave a few details, and then we'll get it sent out to you. Again, doesn't matter if you're a member or not. It's just a way of us sort of giving you something for free. And that QR code is also in the top left corner. So if you haven't done it, fear not. You can scan it anytime and do it while I'm speaking. So yeah, like I said, just a little bit about BMA membership. I'm sure you're all members or you've been members, maybe not quite sure what you get as a student. I appreciate some of you guys on here are junior as well. So I'll try and sort of keep it for everyone. So yeah, so we're the trade union and professional association for doctors and med students in the UK. So represent you individually, nationally, and locally on all the issues that affect you. So we've been going out to the juniors and everyone really recently about obviously the pay uplift deal that we've not agreed, and sort of what actions to take next. So we've been surveying everyone, so keep an eye on what happens next, whether that be something like industrial action or remains to be seen. But yeah, I know we're all not happy about it. So yeah, so we're not an indemnity company, so we're not like MDU or MPS. We don't deal with patient complaints. We're here to look after you, your development, and your working conditions. So things like your contract, your pay, and well-being. So yeah, if you're a membership, we can basically just support you, and you can get in touch with us at any time. So yeah, so we have employment advisors based at every single trust and every single med school across the country, so they know all the stuff that they need to know to get things sort of sorted. We also have industrial relations officers, so sort of the bigger issues, they go to the trust and sort of fight on a whole sort of on everybody's behalf when there's a bigger issue. But yeah, in terms of individual problems, there's always someone at your trust that you can speak to, or the med school. As a member, you obviously get other benefits. So I'm sure you all know the BMJ, the medical journal. So as final years and above, you actually get that through the post every week. So if you're in your final year and you're not getting it, just give us a ring and just say, yeah, I would like to receive it through the post weekly. It's no extra charge, and it will just be a case of us making sure we got the right address for you. Alternatively, if you don't want it through the post every week, you can always just opt for the app version, where you can read old and new editions. So yeah, being a member also means you have access to our clinical and non-clinical learning tools. So you have full access to BMJ Learning, which has over 1,000 clinical and non-clinical modules. It's all very, very interactive and kept up to date with all sorts of the latest developments. And yeah, for each module you do, you can also get a certificate as sort of proof of learning as well if needed. So yeah, in terms of BMA Library, so BMA Library, BMA House is closed still due to COVID, but we're sort of we've got like ebooks and e-journals that you can access instantly on your phone or laptop. So that's sort of the route that the BMA library is taking at the moment. There's a new tool, it's called Clinical Key. So it's essentially a search engine, a medical search engine. I know a lot of people have come across Clinical Key before, but now it's part of BMA membership, so it's another benefit. Really good to use at point of care, and it's got lots of step-by-step procedure videos, and just lots of breakdown of everything you need to know, really. If you're thinking about your medical, your specialty options already, you can use our specialty explorer tool. So that one gives you a bit of a good picture of what would suit you best. So it's an online psychometric test which takes about 20 minutes to complete. It asks you all sorts of work-life balance questions, and then it'll give you a detailed report listing the top suit specialties according to the answers that you've given. Really easy to use and covers all specialties, and the reports are always really interesting and thorough, with lots of like graphs and charts to break things down. If at any time you feel you'd like to speak to someone about your well-being, we have services that are open 24/7 to all students and doctors, and you'll have the choice of speaking to a counsellor or a peer support doctor. So this one's a telephone-based service, and we do offer video calls as well if you like that. And yeah, if it's more than a singular call to the service, we'll make sure that you speak to the same person. These calls are confidential, free of charge, and open to everybody, so it's regardless of whether you're a member or not. So yeah, if you're not currently a member, there's an offer because I've come along today. If you join, you get a £10 Amazon voucher, and also you wouldn't pay anything for the rest of this month. So you don't start paying from October. If you are finding it, it's £3.66 a month. So £10 Amazon voucher is like getting 3 months free. So yeah, it's very good. Very good deal, good time to join. So yeah, just use that link on the screen or the QR code. And also for F1s, if there's any F1s here, it's £9.75 a month, but you get, but it's tax deductible, so you get a couple of pounds back each month, so it goes down to about £7.50-ish. So yeah, and just to wrap up from me, yeah, just one last chance to sign up and get the employment guidance support pack, and we'll stay in touch about just other benefits and go over sort of what I've already told you. But yeah, if you are a member, I would just encourage you to use your membership more. There's lots of good tools out there to use, lots of revision stuff. Yeah, I'll hand you back and I'll let you crack on with the start of the session. Thank you for having me as well.
Brilliant. Thanks so much, Dan. And yeah, I've put those links in the chat. So if anyone wasn't able to get the QR code, you can also just get the link from there. All right. So now going to hand over to Wendy, who's just going to give us a really useful talk on verification and certification of death.
There you go. All right. Hi everyone, my name is Wendy. I'm a F2 working in Manchester at the moment, and today I'll be talking about verification, certification of death. With me I have Adi, who's sorting out the Zoom, and Tasneem, who's going to be reading out any sort of questions that you guys have and any sort of answers that you can pop on the chat box. We'll try and make this as interactive as possible. So if you have any sort of questions or anything, feel free to pop them on the chat box, and Tasneem can read them out to me because I can't really see them. But yeah, let's go ahead. So things that we're going to go through today, I'm just basically going to talk about the introduction and the aim of why we're doing this teaching, a little bit on death verification, the assessment itself, what to do before, during, and after, a little bit on death certification as well, what difference between that is, and what's the difference between that and a cremation form is, and then within that we'll give you some tips when being on call as well, and on how to speak to family members. And then lastly, I have some questions and some cases for you guys to do as well, so we'll try and make this super interactive. So death verification and certification is a common task when you're on the wards or on call. It can be very daunting at first if you're unsure of the process. I remember the first time being asked to go and verify a patient's death on the ward. I just wasn't sure what to do, so I had to grab an SHO to go and watch me do it. And he gave me feedback at the end and basically watched me document as well, and saw what I did and said whether it was appropriate or not. So it's quite useful to have someone sort of feedback to you, you know, when you're doing it for the first time. But hopefully this talk will help prepare you if you have any sort of questions or anything. Then, you know, it's a safe space, you can always ask anything. In medical school, you might have been taught about death verification and certification. You might have been taught the theory of it, or might have some simulation, but real life is a little bit different. So the aims of today's topic is going to be the basics of death verification and certification. tips on what to do on call and how to speak to family members, and then basically where and how to seek for help if you're unsure. So what is the verification of death? If you guys know of any sort of definition or any sort of simple terms, feel free to please pop that in the chat. I'll give you a couple of seconds and then we can move on. Anything on the chat box?
Yeah.
All right, that's all right. So in simple terms, verification of death just means confirming death. You're not certifying it per se, you're not filling in the form, you're confirming death as opposed to anything else. What that means is you're ruling out if there has been a hypoglycemic event, if the patient has had a vasovagal, for example, passed out. So you're confirming that the patient has definitely have passed away and there has been a loss of life. And it is an important task to do because you're legally establishing it. The patient's not pronounced dead until you've established the time. Until you've finished your assessment, document the time, then they're legally established as dead. In clinical settings, in hospitals, most of the time you'll be the ones, if you're junior doctors on the wards, you'll be asked to do it. So medical professionals, registered nurses and paramedics who have been trained can verify a patient's death. It's just good. In non-clinical settings, most of you will not be involved in that. If you're junior doctors, it will be mostly GPs or paramedics, but it's just good knowledge to know. In light of COVID pandemic, apparently non-medical professionals as well are allowed to verify death with remote clinical support. But that's not really relevant, it's just something to know about. So you'll be asked this a lot on the wards, whether you're on call or working around on the wards, you can get a bleep and then staff nurse will say, "Hi doctor, please can you come and verify Mrs. A's death?" So there are a couple of things that you need to ask the staff nurse when you're on the phone, for example. What would you want to ask them? If you want to pop that on the chat, and we'll wait a couple minutes and see what answers you come up with. So these are just questions that you want to ask the staff nurses before you actually go and verify the patient's death. So what kind of details would you want to know?
So Jamie Lee has asked where the patient is.
Any other answers?
Jack has asked, Ollie has asked, could there be any reversible causes? And Karen has asked, is it an expected death?
Yeah.
Mustafa is asking, does the patient have any comorbidities? And Theodora is asking about other diseases the patient may or may not have had.
Yeah, so perfect. So those are the main questions you want to know. You should ideally try to gather as much information as you can when you're on the phone. Things like the things that you guys have mentioned are perfectly correct. So things like DNA CPR, you want to find out a little bit about the patient's background, why they've been admitted to hospital, what was the day team's plan, have they been pallated, and is this an expected death or a sudden death, especially DNA CPR, whether that's in place or not. That's the main important thing before you go and verify the patient's death. Also, I think someone mentioned about where the patient is. That is obviously a very key detail to get. If you're trying to go to a ward, you want to know, where exactly this patient is. And yeah, and other details as well as the patient's name and their age as well could be relevant, just so when you go on the ward, you can ask who this patient is. So I've written a set of things that you should be asking before verifying a patient's death. So like I mentioned earlier, valid DNA CPR should be in place. Check their resuscitation status. If they are not for resuscitation, then you can continue to verify the patient's death. If DNA CPR is not in place, then CPR should be commenced until resuscitation status is found. I've had a call in the ward before when I was on call, like a bleep from the nurses to ask me to go and verify a patient's death. And I remember asking for a DNA CPR, and I remember hearing them saying that they did not they did not know whether DNA CPR was in place or not. And me and Maraj were just looking at each other and we'd be like, does this need to be a crash call? Because if the patient stopped breathing and they don't have a DNA CPR in place, CPR has to be commenced and a crash call has to be put out. So that's an important thing to think about. Next, just need to make sure that there's no obvious need to refer to the coroner or police. Just rule out that the death is not suspicious or requires any sort of investigation before you go and verify them. And then once you've gotten all the information ready, just need to get all your stuff ready because you don't want to be fumbling around when you go and verify a patient's death. You want to get several items such as a pen torch, stethoscope so you can listen to their chest, clock so you can verify the time of death, pen so you can document, and PPE when you go and see the patient. In community, I believe there is a 4-hour time limit before patient, where the maximum limit where the patient has to be verified. But in the hospital, it's important to go and verify patient's death promptly. I know when you're on call, especially when you're on medical on call, you can be really, really busy with a lot of different important jobs, seeing really, really sick patients. Obviously, go and prioritize the sick patients, but you need to think about doing this as soon as possible as well, especially if you're doing it around like 10, 11 p.m. before midnight. So let's say if they passed away on the 15th of September at 11 p.m. and you go and verify them like around 1 a.m. The date would change. It would technically be the 16th of September, and that's the date that would be written on their death certificate. And some family members would not be very happy with that. So just think about that if you've been asked to verify a patient's death. So before verification of death, as I mentioned earlier, it's important to speak to staff members looking after the patients, speak to the nursing staff to find out what happened, look at their notes themselves. You must confirm that they have that purple form DNA CPR in place, confirm their details, read up on them if you're not sure. And then if the family members are around, sometimes staff nurses, the staff on the ward would ring their family members to ask them to come in if they know it's an expected death, and they might already be, by the patient's bedside when they have passed away. So if they're around, do go and speak to them and offer your condolences and explain why you're there. And that's really quite an important bit and a little bit daunting when you're starting out. So I've written a page basically on top tips on what to do when you're speaking to family members. So you don't want to, when the family members are in the room, you don't want to just barge in and just verify this patient's death. You want to go in, first of all, offer condolences, explain why you're there. So explain in non-technical terms, especially what you need to do, what you're about to do. Some family members can get quite touchy and confused, like why are you examining, the patient when they've obviously passed away. And so that's why you need to explain fully what you're about to do, like shine a light, like light in their eyes, listen to their chest. And this is important because I need to legally establish time. I need to do it in a certain amount of time. You should also offer options. because it might be quite distressing for them to watch you do this, you can offer them the option of either staying in the room or waiting outside. Things that you should not do is you should manage expectations. You should not over-deliver on promises. For example, if you tell them like the death certificate would definitely be completed tomorrow by the ward team if you're on nights, that's something you should try not to do, because the family members are already quite distressed, and you don't want to, distress them even further by telling them information that you're not sure of. So I have a sort of phrase that I've written on the left side of the page, just something simple that you can say to family members when they're around. So I usually say, "Hi, my name's Wendy. I'm one of the doctors on call tonight. I'm sorry for your loss. I've been asked to verify Mr. A's death by the staff members on the ward. What this involves is, this involves me checking for any sort of signs of life. I need to listen to their chests. I need to shine a torch into their eyes with a pen torch just to see if there's any sort of reactivity, and I need to do other tests as well. Some relatives can find this quite uncomfortable and distressing when I'm doing this, so you're welcome to either stay in the room when I do this or wait outside for a few minutes, and I'll come and let you know when I'm done. I understand it's quite a distressing period of time, and if you have any sort of questions, please feel free to ask me, and I can try and answer them as best as I can. If not, I will try and hand the questions over to the people who might know better. So yeah, that's the short phrase that I usually use when I'm speaking to family members. Yeah, so that's all the stuff that you do before. So now we'll go into the assessment bit. So the assessment bit is really quite simple, really. Most of the examination is done mostly on the chest when you're listening. But what are the main things that you need to do when you go into a room? You've prepared all your stuff, you've read all the information, you've seen that there is DNA CPR in place, you've spoken to family members. What should you be doing when you enter the room? You pop the answer on the chat, and Tasnim can read them out. I'll wait a few minutes. Any answers yet? No.
Not that I can see.
No. Anything you guys would do when you enter the room? You've spoken to the family member. What do you think you should check for first of all? What's the consensus on there?
So Mustafa has said signs of breathing and heart rate.
Mm-hmm.
Karen has said to confirm patient's identity.
Mm-hmm. Yeah, that is perfect. That is the main thing you need to do. You obviously you don't want to verify the wrong patient's death. How you should do this is you should check the wristband that they have, and then verify it against the notes that you have. That's the first thing that you should do first of all, and then you can go ahead with the other examinations. You can be surprised at the amount of people who forget to check the identity when they enter the room, so that's very important. Next thing to check is to do a general inspection of the patient, and the bedside area around them as well. You would do this with almost every examination that you're doing. So stand at the end of the bed, look for any sort of obvious sign of life. What does the patient look like? Their general appearance, their skin color, and if they have any sort of monitoring or ECG leads attached to them. And have a look around the room as well to see if they have any sort of cannulas on them, any sort of catheters attached, any sort of pacemakers from the end of the bed if you can see any. That's just something important to do before you dive into the examination. And then even though, the patient's obviously unresponsive, really can't speak to you, if the family member's in the room, I like to verbalize everything I'm doing, just so the family members know, exactly what I'm doing, just so they're not just sitting there and watching me. And I like to sort of just introduce myself as well, just with every other patient. Hi, my name's Wendy. I'm going to listen to this, do this. So first of all, I would check if the patient is unresponsive to verbal stimuli. So you would just shout their name and see if there's any sort of reaction. And then check for painful stimuli as well. There's two things that you can do. You can do supraorbital pressure, trapezius squeeze, and then if there is no sort of response, then you can move on. And like I said earlier, most of your examination and assessment would be focused on mainly the chest. It can seem like you are spending a lot of time just using your stethoscope and listening to their chest, and you were meant to do it for 3 to 5 minutes on different sections in this area, which we'll talk about later. But it's important to just do that, just to confirm that there's definitely no breath sounds, definitely no heart sounds. So when you're on the chest, auscultate and observe for the absence of respiratory effort for 3 to 5 minutes. That can seem like a long time, but you can listen to each section of their chest for 30 seconds, and then move on to 30 seconds. And then while you're doing this, you can always just, have a look, do a more closer inspection of their chest. You can check for any sort of devices. Is there a pacemaker? Is the chest wall rising and falling? Are they breathing? So that's why you need to spend quite a long time in this. And then next, check for the continual absence of heart sounds or asystole on ECG monitoring. So once you've listened to the chest, listen to the lungs, listen to the heart sounds as well. So just aim for 30 to 40 seconds in each area on the 4 seconds of the heart sounds, as I meant, just like the chest sounds, just so it doesn't seem like a very long time. And then after that, after you spend majority of the time on the chest, check for central pulses, check that it's absent for about 1 minute. And then once that's all done, check the eye, check for the absence of eye reflexes. So I've written here pupils or corneal reflex, but corneal reflex is rarely performed. And most of the time you just use a pen torch to go and look at the patient's eye. Another thing that I forgot to mention is try and find a pen torch. There will be one somewhere in the wards. There'll be one definitely somewhere in the hospital. Do not use the light on your phone. That's just, not great practice, and family members will not be happy with that. So yeah, use the pen torch, look at their eyes, make sure it's fixed and dilated. And then I've written, lastly, check for any sort of devices such as a pacemaker, because that needs to be removed if the patient's cremated. But you can do this really early on when you're on the chest, listening to the chest, listen for heart sounds and respiratory efforts. You can then do focus inspection and look for things like that. So that will make your life a little bit easier. So once you're done with that, it's really quite a simple, assessment. It's really not very long. Most of the time is spent on the chest. And to be honest, most of the time is spent, gathering all the information beforehand and then documenting it very clearly afterwards. So yeah, after the verification of death is done, 3 top things that I usually like to do. So you need to show respect to the patient and their family members. If, you open their eyes to shine a pen torch in there, make sure, you close their eyes again. And then if you remove a blanket to listen to their chest with a stethoscope, make sure that they're covered afterwards and their dignity is maintained. And then afterwards, document your assessment very clearly as well. I have a page after this with, talking more about the documentation, but the timing especially is important because, as I mentioned earlier, they're not legally verified as dead until you've done your assessment and document the timing. So it's important to look at the clock. Once you've finished your whole assessment, look at the clock and see what time it is, and that will be the specific time you write on your documentation. And then the time that you write on your documentation will be the one that's transferred over to the information that would be written in their crime form or their death certificate. So that's just important to know. And then lastly, obviously, if the family member's still around, speak to them and tell them what the next process is, if you know. If you're not sure, ask the staff members in the ward, or ask the bereavement team, or ask the senior doctors on call with you as well. If they're not around, then it's important to ring them up to inform them of their relative's death. Most of the time, this will be done before, hopefully. The staff nurses, if it's an unexpected death, family members would already have been told about it. But yeah, if you did verify their death, then it's important to, let them know. So I have a page on an example of documentation here. There are some things that are missing on it. If you guys want to have a read and then, pop your answers on the chat on Facebook and let me know what you think is missing. It's not a very good documentation. There's some key things that are not on there. Yeah, I'll give you a couple minutes to do that, and then Tasneem can read them out once you guys are done. So there are certain key things that are really missing from this. The good thing is some hospitals have a fail-safe sort of system where they have like an online system where all these assessments are populated and you just have to say yes, no, yes, no. That's the case in my hospital anyway. But if it's not online and you're asked to write it up or type it up, then there's some stuff not on this page.
So a lot of people have said time and date of verification.
Mm-hmm. Yeah.
And Martin has said absence of a DNA CPR.
Mm-hmm.
Chinbuku has said that there's no patient identity.
Yeah.
And Martin has also said that the doctor's details or the healthcare professional's details are absent.
Yeah, definitely. Yeah, so is that the general consensus then? So yeah, as you can see, there's no patient details on this documentation. I mean, whose verification of death is it if there's no sort of patient details? Who is it written for? There is also no documentation of the doctor who's verified death. Ideally, you should be writing your full name, your GMC number, and then as at the bottom of the page once you're done as well, and maybe a bleep or a contact number, so that the nurses can contact you if they need you, or the bereavement team can contact you if they need you. Other things that have been missing that were mentioned as well, I think the most important one, which is the time and date of death. So as I mentioned earlier, that's the specific one that will be transferred over from your documentation to their medical certificate cause of death and to the crime form. So you need to write the specific time of death on the bottom of the page, on the top of the page. As you can see here, it says that he stopped breathing around 11:30 p.m., but that's not really, that's not verified as the actual legal time of death until you've done all your assessment. Assessment-wise, all the information are on there. Other things, you could write a short summary of the background of why backgrounds of the patient, why they were in hospital and what has happened while they were inpatient, and if there were any sort of concerns or anything from the nursing staff, that would be a good thing to document as well. But one of the things that have not been documented here is also the presence of pacemaker. So as I mentioned earlier, any sort of pacemakers, that needs to be documented very clearly, because when you're filling a cremation form out, there is a section where you need to say whether a pacemaker is present or not, and they need to know that before the body is being cremated. And if that is not very clear on your documentation, then the doctor who would be doing the crem form would then have to probably go to the mortuary to confirm that there has not been a pacemaker present. So there would be double work involved. So you don't want to, add extra work for the other person. So yeah, key things that I mentioned earlier: patient details, a little bit on the background of the patient, and then full assessment, as what we've mentioned earlier. So check your identity, voice, pain, stimuli, pulse, heart sounds, respiratory sounds, pupil reflex, and then presence of pacemakers or not, any concerns from the nursing staff. And then another thing that I forgot to mention is if the family members are around, do write that down on your documentation as well. And then lastly, your name, your GMC number, and your bleep or your extension number. So after you've done all of that, you've documented everything. These are the key things to just know so you can mention to the family members. This might be different in some hospitals, but once you've verified and you've documented, the body will then be taken to the mortuary, and then the bereavement team will then be in contact with the family members regarding the next process. I left it kind of vague there because it's different in different hospitals, and in order to find out more, you just need to get in contact with the bereavement team. But as I mentioned earlier, if you don't know, you're not really sure about anything, always just ask a senior member of your team, and always ask for help from the staff members on the ward. They might know about the process a little bit better than you, and then get to know the bereavement team as well, because they are experts in this. So lastly, tips on speaking to family members again after you've done your verification. As I mentioned earlier, only offer information that you know about. So if the family members have any further questions about what happens after verification, and if you're not sure, then direct them to the direction of people who know better. Try not to overpromise as well, as I mentioned earlier. And these are the people you can get help from: staff nurses, bereavement team, senior doctors and consultants. There's always help everywhere if you ask for it. Before I move on, do you guys have any sort of questions or anything? I'll give you guys a couple of seconds to just pop that on the chat box. If not, we can move on to questions to answer. So I'll put that on the next page anyway, so you can read that and then pop the correct answer on the chat box. If you have any sort of questions as well regarding what I've just mentioned, do feel free to pop, and I'll try to my best to answer.
So the general consensus is number 4.
Mm-hmm. Any questions regarding what I've mentioned, like in the previous slides?
No questions.
Okay, no worries. Yeah, so sorry. Yeah, the correct answer is number 4. So you have to be appropriately trained to do this. Unfortunately, this webinar, I don't think is a training session. So if you, work in a hospital and have been asked to verify a patient's death, please do not refer to my slides. You have to be appropriately trained, I guess, by the trust itself. Next question. So what is important document on your notes other than the absence of vital signs? It's quite an important thing.
Wendy, I've just seen a question.
Mm-hmm.
So someone has asked, what would be appropriate PPE for death verification? And a second question, where is death verification normally done? Is it normally on the wards, in rooms, or in the mortuary?
Okay. First question, PPE wise, in the hospital that I work, it's basic pinnies, the plastic thing that you tie on the pinnies, and gloves and masks. So you wear the mask everywhere in the hospital anyway. But those are the key things that we use before we go in. It's the same thing as we use before we go and examine any sort of patients anyway. So we do that with death verification. It depends, obviously, if the patient is COVID positive or not. There might be different rules in different hospitals. But yeah, that's the general PPE that I have to wear in my hospital. In terms of location of where you would be verifying death, it's mostly around the wards. I have not personally verified patient death in the mortuary before. Most of the time it's done directly on the ward itself, because the staff nurses will ring up the on-call doctors to go and do it as soon as possible. So yeah, so that would be the main location. Any sort of consensus on this answer? Question, sorry.
So most people have said number 2.
Yeah, that's quite easy. I've mentioned the pacemaker thing like a million times because it is really important. And it's important to definitely document that down so that somebody else doesn't have to do, the work again. So yeah. Next, we'll move on to death certification. So I've written a little bit on the death certification process, what to fill in for the cost of death section, and I've also written a little bit on cremation form. So the medical certificate of cost of death is the form that you'll be asked to fill, and cremation forms, if the patients are to be cremated, are very common forms that you'll be asked to fill as junior doctors. And they are very important documents. They are legal documents, so you have to be honest and trustworthy when completing it. If you're not sure on how to do it, always seek for help from a senior doctor. And if you're an F1, always just get your senior consultants to have a look at it before you go and fill in 1A, 1B, and 1C, which we'll talk about later. It's an important form, obviously, because family members use this to register death. It is required by law in the UK for death to be registered within 5 days of occurrence, unless referral to coroner or an inquest is made. So that's why it's important to get it done promptly. Other things, who can do it? So it can only be completed by the doctor who's looking after the patient in the last 14 days, and it's 28 days in Northern Ireland. I believe in COVID times, they might have also changed this in England to 28 days, but let's just stick to 14 days. The person who's looked after the patient in the last 14 days would be the person who would be asked to fill in a death certificate. Before you complete the death certificate, a couple of things that you should do. If you're very junior as an F1, speak to your senior or your consultant to determine the cause of death if you're unsure. And make sure you sort of read the notes as well and know the circumstances behind the death. You might know this patient really well because you will be asked to complete this form if you've looked at the patient in the last 14 days. So you already sort of know the information about them. But just to find out more information about what happened during the last few days before they passed away, just read the notes properly and know the circumstances. And then get familiar with the bereavement staff members as well. They're often very friendly, very nice, and they're experts in this as well. They've seen so many junior doctors, F1, F2, struggling with filling up the form, so they know what needs and what does not need to be on the form. So just ask them for help if you're unsure. But definitely clinically wise, if you're not sure what should be the cause of death, definitely speak to your consultant or your senior members of your team. There are a few things that needs to be referred to the coroner, and these causes are quite, they're quite, how do you say that? It's quite obvious. So if the cause of death is unknown, so sudden, unexpected, suspicious of violent or unnatural death, then that should be referred to the coroner. Death resulting from injury, poisoning, alcohol or drugs, which are not chronic use, doubtful stillbirth, surgery or anesthetic, if they've been admitted within the last 24 hours, any death in prisons, if they're unknown, any death from industrial disease like asbestosis, death from neglect, want, or exposure as well, that all of these should be referred to a coroner. It's quite a long list of stuff to remember, but just to let you know that if you're filling up the medical certificate of cause of death, there is a section of this at the back on the back page. So you can always just refer to that as well. And like I said, if you're not sure, ask the bereavement team. But yeah, these are the stuff that you should refer to the coroner. This is what the medical certificate of the cause of death looks like. It's normally an A3 page piece of paper, quite a long, big piece of certificate with an inlay sort of section in the on the left side. So it's essentially like a piece of certificate that you tear out and give to the family members. On the inlay section, it's literally just a summary of what you've written on the certificate itself. It's just for record keeping, and then this certificate would then be scanned, and sort of the real certificate would then be given to the family members. There is a couple sections that you need to fill on this. The most confusing section is the cause of death, but we'll go through that later. But here is just like patient details, which I'll talk about here. So main things to fill on the top is the patient's information. So their main details, their name, their age, and the date of death as stated to you. So like I said earlier, it's important to document, if you're the person verifying the death, the specific, the date of death as clearly as possible. It's written in the format of X day of month and year. So for example, it's written on like here, so day of blah blah. So it can be a little bit confusing. I remember filling this up before and being like, where do I write the month and where do I write the year? But this is just the format. So 19th day of April 2019, for example. And then place of death would usually be the hospital that you're working in, or the hospital where the patient's passed away. And then last seen alive by me is also in the same format as the date of death. So might be a couple days before. So the 17th day of April 2019, for example. And then this section, you just have to sort of circle it. So it just says if post-mortem will be taking place at all. So if post-mortem is not being held, most commonly, that would be number 3. And then this section is who've seen the patient after death. So if you were the one who's verified the patient's death, then it would be A. Or if you've seen the body after death, then it's A. If it's seen by somebody else, then it's B. Unlikely it will be C, not seen by death by a medical practitioner. But yeah, just fill in the answers as correctly as you know it to be true. And then next would be the cause of death. So this is the section, as I mentioned earlier, which gives people, the most confusion. If you have any sort of doubts or any sort of questions regarding this, always, like I said, go and speak to the senior members of your team or your consultants, and they'll be able to point you in the right direction. In some hospitals, there are also medical examiners that are present as well, that you can discuss what you've written as section 1B and 1A, 1B, and 1C with them. And then they will, they'll do the same thing. They will read through the patient's notes, and then based on that, they will then confirm if what you've written is accurate or not. But yeah, let's say you're just doing this section on your own. 1A is basically the disease or the condition that directly led to the patient's death. 1B is the thing that led to 1A, and then similarly 1C led to 1B. So, and then section 2 is just the other significant conditions contributing to death, but not related to the disease itself. So this is not a section that you should be filling. You don't fill this section as the full patient's past medical history, just significant things that have hastened the death. So top tips for completing section 1. Consider main sequences, as I mentioned, that led to death. So think of the main things that directly led to death in 1A, and then think of other things that have led to 1A. So write that down in 1B, and then 1C, what has led to 1B happening. And then be really specific about the cause of death. So if they passed away from lung cancer, for example, do not write lung cancer. There's specific information like lung adenocarcinoma. So be specific. And then mode of death and old age ideally should not be written on section 1, but I'll talk about that in my next slide on stuff that should not be written on section 1. And then some cases only have one condition that led to death. So in that case, only 1A section would be completed, and that's completely acceptable. So things like subarachnoid hemorrhage, if you just write that in 1A with nothing else in 1B and 1C, that's completely fine. And then in some circumstances, 2 separate conditions could have led to the death directly. So in that case, you should enter them both on the same line on 1A, and then in brackets state that there are joint causes. And then lastly, do not use abbreviations. So things like type 2 diabetes, COPD, I've written that so many times out of habit on the forms and been asked to change them. So do not write COPD, write the full name of what it is. Do not write T2DM when it's type 2 diabetes. Yeah, those are the top things that you need to remember. So things that cannot be written in 1A, any sort of failures like renal failure, respiratory failure, everything, all of these should not be written on there except for congestive cardiac failure. Old age and frailty should ideally not be used as a sole cause of death, unless you can't find any sort of reasons for the cause of death and they're over 80 years old, then that might be an acceptable cause of death in 1A. Mode of dying, like cardiac arrest, respiratory arrest as well, should not be written on 1A. And then other things that are not allowed are asphyxia, asthenia, coma, exhaustion, or cachexia. So these are the things that you just need to remember that should not be on 1A. Like I say, section 2 is things that did not lead to death, but sort of played a role in hastening the process. This is, like I said, not a section to write the patient's past medical history fully. You need to pick and choose whichever might have hastened and hastened the process of death overall, but not directly led to death. Can be a little bit confusing to know which is which, but we'll do some example cases later, and you guys can let me know. And then now just a little bit on cremation form. So in England, Scotland or Wales, if a patient is to be cremated, separate forms need to be completed. And again, this needs to be accurate and legible as well. So cremation form 4 and the medical certificate cause of death are both separate forms in England anyway where I work. That just applies to patients who are to be cremated. So the cremation form 4 is usually the one that you'll be completing. It's completed by the medical practitioner who saw and treated the patient in the last 14 days before they before their death. This is normally the same person who's completing the death certificate as well. And there's also another crem form, which is crem form 5, and that will be completed by a senior doctor who's fully registered for at least 5 years. And they will be completely independent of the doctor who signed crem form 4. And they're usually not involved in the care of the patient. Crem form 4 is the main one that we're focused on because that's the one junior doctors will be asked to complete. It is essentially, you have to fill in the same sort of information as the medical certificate cost of death as well. You have all the patient details on the front. I think there is a section on it, like a summary of like the summary of details of what happened to the patient, you know, from the beginning to the end of like why they came to the hospital, what they were being treated for. And then there's also a section on you know, 1B, 1A, 1B, and 1C, just like in the medical certificate cost of death. And then there's also a section on whether the patient's had surgery or not. And then lastly, important things that I mentioned earlier that was on the crem form was the presence of a pacemaker or not. So yeah, that's why it's really important to document it when you're the one verifying the patient's death. So now we have a few example cases for you guys to do. I have 2 cases here. This is basically just the patient's past medical history and the history of when they were seen on the ward round. I've written a typo over here, please ignore that. But if you guys could think about what you want to write on 1A, 1B, 1C, and number 2, and then we can go through the right answers after this. So I'll give you just a couple of minutes to complete this, and we'll just gather the general consensus on what is the right answer. And yeah, we can go through that later.
Hi, Wendy. I'm still waiting for the comments to come through.
Oh, no worries. So just think of the basic main thing that have caused this patient death, and then work your way, backwards. Number 2, as I mentioned earlier, is the thing that hastened the patient's death, but not directly causing it. So yeah. If you're not sure, we can go through the answers as well, but just have a try. Pop it in the chat box if you have any sort of idea.
So Theodora has set an option for what could be written in 1A, could be bleeding.
Anything else on 1A?
Other people have said esophageal varices. And for section 2A, liver cirrhosis.
Okay, should we go to the answers then? So that's what I've written on 1A, 1B, and 1C. So like I said, just think of the things that, the main thing that have caused, you know, the loss of life, and that is the bleeding itself. So I've written massive hematemesis, and the thing that have caused that was the varices, and the thing that have caused the varices was the liver cirrhosis. Other significant conditions contributing to death, I didn't really fill that in because I didn't think that was relevant. Frequent falls, COPD, I didn't think that was relevant to be written on there. But yeah, that's the answer that I've left. Yeah, so we have another case after this. This is a second case. I'll read that out for you guys as well. Just while I'm reading it out, you guys think of what you need to fill in 1A, 1B, and 1C again. And number 2, remember 1A is the main thing that have directly led to the patient's death. 1B is the thing that have led to 1A, and 1C is the thing that led to 1B. And then number 2 is just basic, the condition, any sort of condition that hastens death. So in this is a 60-year-old male with past medical history of ischemic heart disease, basically seen on the ward round yesterday with your consultant, has been admitted 8 days ago with a fractured NOF of his right leg. NOF is neck of femur fracture. Sorry if you don't know that. Of his right leg. Had an operation a week ago. And he has been complaining of calf pain 3 days ago, seen by a doctor in a ward and started on low molecular weight heparin. Unfortunately, he was really unwell a couple of days later, complained of chest pain and breathlessness, and then verified to have passed away on the 11th of September 2021 at 3 p.m. So think about what goes on 1A, 1B, and 1C, and number 2 as well. Any consensus so far on 1A?
So a lot of people have said pulmonary embolus for 1A.
1A, yeah.
Others have said cardiac arrest and blood clot, or PE.
In 1A?
Yeah, for 1A.
Okay. What about 1B? Any consensus from that?
1B, the most common answer that I can see has been deep vein thrombosis or ischemic heart failure.
Yeah, and then anything on 1C?
In 1C, I've seen right neck of femur fracture or femur fracture or heart failure.
Okay. And anything on number 2?
So for number 2, people have mentioned ischemic heart disease and ischemic heart failure.
Okay. Yeah. So as I mentioned earlier, 1A should not be the mode of death. So cardiac arrest, respiratory arrest should not be written on there at all. But this is what I've written as 1A, 1B, and 1C. So the patient is unfortunately, if you think about it as the sequence, so they had a fracture of femur of their right leg that was operated on, that have led to higher risk of DVT happening, and that was what that was suspicious of when the junior doctor on the ward started the patient on low molecular weight heparin, and the deep vein thrombosis could have led to a PE forming, which then the patient then present the next day with shortness of breath, chest pain, difficulty breathing. So that's the whole sequences that I was trying to get you guys to think about. Number 2, ischemic heart disease could be something that could have hastened the death itself. So that's something that I've popped on there. What was I going to say? Anything anyone want to mention about fracture of femur right leg? So remember, it was operated on. So anything that has had an operation, as I mentioned earlier, should be referred to the coroner as well. Even if you think the operation itself did not lead to death, as I'm on the list of the the things that should be referred to coroner, says here any sort of death related to surgery or anesthetic. So they had a knot which was operated on, which could have led to the the DVT, which then could have led to the PE. So that's something to think about as well. If you're unsure, like I said, speak to the bereavement team, speak to the staff members, senior members on the ward. But yeah, well done, you guys. General consensus. Couple questions and then we'll be done. So if you guys want to fill in on the chat as well what you think the most accurate answer is in here. When is death certificate not required? So there's 4 answers on there. If you pop what you think is the right answer on the on the chat box, and then we can have a discussion. So 1 is before 24 weeks of gestation, a fetus delivered with no signs of life. Number 2 is after 24 weeks of gestation, fetus is delivered with no signs of life. After 24 weeks, delivered with signs of life before it dies, and then after 24 weeks where an abortion is performed. So which one of these is a death certificate not required? So remember, it's not required rather than required. Because I always get that wrong when I'm answering MCQs. I always forget to read the not. Any consensus?
So the general consensus coming through, it has been number 4, although a few people have said number 1 as well.
Okay. So the answer that I popped on there is number 1. So I don't know if you remember in the refer to coroner bit section that I've written earlier. Sorry, no, that's not relevant. Sorry. I believe it's number 1 before 24 weeks of gestation, if a fetus is not delivered with no signs of life. I think that is considered a miscarriage rather than a stillborn. So if that's the case, then death certificate is then not required. But I can see why you would think after 24 weeks when an abortion is performed would be the case as well. I guess when an abortion is performed after 24 weeks, it is considered after 24 weeks, you need to do a death certificate for any sort of fetus. So that is just to get you thinking. After 24 weeks, you do need to fill in any sort of death certificate for someone who's passed away. Before 24 weeks, I guess it's counted as a miscarriage, and that's not, you don't really need a death certificate for that, if that makes sense. Few more questions. What is the name of document given to relatives to register death? This is quite a simple one. Like I said earlier, I popped that on the chat box for the correct answer. So this is the one that, the one that I've showed you guys earlier, that you have to fill in 1A, 1B, and 1C, and number 2 on as well. And that's the one that, the relatives will take to register the patient's death. And that's the one that I also mentioned, that it has to be done within 5 days after the person, after death has occurred, unless referral has to be made to the coroner or an inquest has to be done.
General consensus is 2.
Mm-hmm. Yeah, it's quite a simple one. Yeah, number 2. Oh, I've already got the answer on this, sorry. But which ones of these are correct about the MCCD? This is just to get you thinking as well. Part 1 is the immediate cause of death, things that directly led to death itself. And part 2 is the conditions that contributed to death. So remember, it's just think of the things that have directly led to death itself in 1A, and then think about the sequences that have preceded it before. And then number 2 is just things that have contributed to it, but not directly led to death itself. Yeah. So that's the end of my talk. A little bit on a summary and take-home points. So key points to remember is if you're unsure of anything, always speak to your senior members of your team and to to your consultants as well if you don't know what to pop on 1A, 1B, and 1C. And number 2, if you have any sort of trouble speaking to family members as well, just always lead them in the direction of the person who can. Other things, the death certificate and the crime form can be quite confusing if you're filling it out for the first time. We have, a section on Mind the Bleep. There are articles on death verification and death certification as well. If you just want to, have a read before you go and do this, before you go and verify someone's death, or before you go and do the certificate itself, just to refresh your memory, that might be helpful. And yeah, that's the end of the presentation. If you have any sort of questions, please feel free to pop them on the chat, and I can try my best to answer them. And if you think of any other questions at some other time, always just feel free to message Mind the Bleep, and we can try to help you as best as we can. There's also a certificate at the end, a QR code that I've popped on right at the end. If you wouldn't mind just, filling it up and giving me feedback, that would be amazing. Yeah, thank you so much for interacting with me as well during this, teaching session. It's really it's a little bit difficult because I can't see you face to face. But yeah, thank you very much. And feel free to ask any further questions and put your feedback on the form as well. You'll get a certificate once you've finished this feedback on Medal. If you've done this before, it's just a really simple short form to fill, and then you get the certificate at the end. And yeah, thank you.
Thanks so much, Wendy. That was a really useful session. I posted the feedback link in the chat in case anyone is unable to scan the QR code. So please do fill that out. It's really useful for us and hopefully useful for you with the certificate as well. We have just one question that's just been posted in the chat by Martin White. It's about patients who are under DOLS, and if they pass away, if they need to be referred to coroners.
No. So let's go back to that slide. Where is that slide? I passed it. Probably passed it. No, I'm not. So as far as I remember, that is not one of the causes that needs to be referred to the coroner. A lot of patients, elderly patients in the ward with dementia have DOLS in place. So that is not a criteria, unless obviously it is sudden and unexpected or suspicious and violent, then that needs to be done. But if DOLS is in place, it's not necessary. Are there any other questions?
That's the only question that's come through. But but to everyone who's still on the webinar with us, if there are any further questions you have, please do drop us a message, and we will pass it on to our team to get back to you. But yeah, I think other than that, we're all ready to wrap up. So thanks everyone for attending, and thanks so much, Wendy, for such a useful session as well. And we'll see everyone hopefully on the next webinar.
Thank you.
Just be 2 seconds.